Thank you, Andy. Ladies and gentlemen, it's still a pleasure to be here. In fact, I think it's even more a pleasure today than yesterday, if that's possible. This is a great meeting, and it's nice to see that it still attracts a very large audience. I was asked to review sepsis in I think what you might call an era where there's been sort of a lot of attention to this topic. In fact, as I was preparing for this talk, it was hard to find a paper that I thought was really important to review that wasn't in the New England Journal. So this is certainly a change for where I think sepsis has been in recent years. These are my disclosures, but I'm actually not going to talk about any of the products those companies make. So obviously I'm going to begin with a discussion around the sepsis definitions. And as you know, we have a new, quote-unquote, new definition for sepsis. If you read this paper and you thought, gosh, it sounds like the old definition, you're not alone. This is, sort of like going to a sequel of a successful movie and seeing that it's pretty much the same movie as the last one. Worked at the box office, why not? But there's some very important things that were clarified in this paper that I think the prior efforts to define sepsis were not as effective in, and so I want to go over those with you. So first of all, sepsis is defined as a life-threatening dysfunction, organ dysfunction caused by a dysregulated host response to infection. Now, we danced around in the community this issue of is the response dysregulated? In the past, we often used the words exuberant inflammatory response. But one of the things we've noticed is that there are some patients that have a very brisk inflammatory response and do quite well. And there are other patients that have a not so exuberant inflammatory response and do very poorly. So this idea that the response is really dysregulated is, I think, important because it leads to a framework where we can look at this condition in a different way. The second, and I think much more important aspect, is that the construct of how one thinks about and defines organ failure has changed a little bit. Now, we'll give Renaldo a hard time when he comes back because he was part of this work group, as was my boss and several of my close colleagues. But one of the things I think they missed an opportunity to do was abandon SOFA, because I don't think SOFA is the right way to look at organ dysfunction. But they did tune it by saying you had to have a change in the SOFA score. That was missing from the prior definition. So you could show up in an emergency department with an infection and on the same 2 liters of oxygen that you were on at home, and therefore respiratory dysfunction, and be defined as having severe sepsis. And that was problematic, right? You could show up with a creatinine of 3 baseline and show up in the emergency department with a creatinine of 3 and an infection, you would technically meet the definition of severe, and that was problematic. So what they've done here is an advance, which is to say it's a change from baseline. It's a change from baseline. So you can't just have chronic organ failure and an infection and call that sepsis. Obviously, septic shock is always a change from baseline, right? We don't exist in the world in chronic hypotension unless you're in an ICU. So you come from home and you're in shock, you have sepsis, and indeed you have septic shock. The third bit that I think is important, or maybe we're up to the fourth now, is there a way to operationalize this outside the ICU, like in the emergency department or on the wards, where you really want to define this quickly? You want to screen patients who have a high risk of having the condition using clinically available information. This is what SIRS criteria was meant to do years ago and didn't really work very well. But you'll see that we still have, as part of this, some of the things that were in the SIRS criteria. So for example, respiratory rate is still here because it's predictive. If you're out in the ward and you have an infection, you have a high respiratory rate, you're likely to have respiratory dysfunction that may lead to failure, and respiratory rates predictive. Altered mental status. This is meant to imply a new altered mental status, again, a change from baseline, and obviously systolic blood pressure. Now, you might wonder why acute kidney injury isn't in here. Everyone gets a creatinine, and indeed that's true, but the problem was that not everyone, and in fact most people, don't have a easily obtainable baseline creatinine, and so a change in the creatinine isn't readily available and therefore wasn't predictive. If you just look at creatinine, as many studies have shown, creatinine is not predictive of acute organ failure because of the conflation with both age-related changes as well as chronic kidney disease. So it's not like systolic blood pressure, it's not like respiratory rate, and that's why it's not there. Now, one of the things I glossed over, I'll just go back to this issue of, I think we know now that this is totally wrong, this idea that hospital mortality is in excess of 40%. And the next thing I want to talk about are some of the trials that have shown that indeed hospital mortality is much lower than we thought it was. Perhaps we knew it was actually lower than this. The hospital mortality in the U.S. with septic shock is about 20%. Now, in fairness, if you include patients that would have been excluded from this trial because they were moribund, about 5% of the patients screened, you get up to about 25%. And obviously, as you saw yesterday, there are important subgroups of patients with endotoxemia, et cetera, that have even higher mortality. But overall, septic shock patients showing up with elevated lactate and or persistent hypotension actually have a hospital mortality of around 20 to 25%. Now, their one-year mortality approaches 40%. But not their hospital mortality. This also shows you, of course, what you already know, which is that there's no difference across these subgroups, groups that patients were randomized to in terms of receiving either early goal-directed therapy, a protocolized standard care, which was sort of a protocol that was put together to kind of mimic what was in current practice, but just standardize it, and then usual care, which meant whatever people were using at the bedside. There was no difference across those three groups in terms of mortality, either at 60 days or 1 year. This was confirmed by the Australians and the New Zealanders, who showed that, in fact, it's hard to imagine these lines being any, you end up with a purple line at the end because the red and the blue are superimposed. So there was absolutely no difference whatsoever, and neither was there a difference with the PROMISE trial in the UK, same exact result. And no surprise, when you put all these trials together, you end up with a superimposed survival curves, again with a mortality at 1 year that approaches about 40%. We further, in this analysis, we looked at a variety of pre-specified subgroups to see whether there was any difference whatsoever in any important groups. One of the most strident hypotheses that have been out there is that these trials didn't enroll as sick of patients as enrolled in the original Rivers data, which isn't true, by the way, by any objective standard. The trials enrolled just as sick patients. But you can look at this in terms of things like Apache as you go up from less than 9 to greater than 14, using just the APS score or looking at the full Apache score. You can see there's just no difference at all. Now you might pick out, well, gosh, it looks like patients with respiratory failure do better with protocolized care, but then you'd have to accept that patients with liver failure do better with standard care. So obviously this is just, you look at enough subgroups and you're going to be doing something. By and large, there's no difference whatsoever, and this table, in fact, goes on to another page, which continues to show exactly the same thing. So there's no difference across these arms of these trials. Early goal-directed therapy is not any better than usual care, granted that usual care has changed over the last decade and a half of sepsis care, and that probably has resulted in the decrease in the mortality rate, but it's not because patients are now already receiving something that looks like early goal-directed therapy. They're receiving something that looks like early resuscitation, which is, of course, something we believe they should have. There is still a marked separation between usual care or early goal-directed therapy and, in our trial, protocolized standard care. And interestingly, these groups, although there was no overall difference, the trend actually goes the other way. The early goal-directed therapy group had the highest mortality. And you might say, well, mortality isn't the best measure. We should look at organ dysfunction. And you can see actually that the lowest new cardiovascular organ dysfunction was still seen. This almost reached statistical significance. Usual care resulted in the best outcome in terms of new cardiovascular events. And the group that got the highest fluid actually had the greatest incidence of new cardiovascular. So it wasn't that you were treating not so sick patients and you would have seen a signal if you'd just had a sicker population or a larger N. And indeed, we chose as our measure of renal dysfunction new renal replacement therapy in the first week, and this was statistically significant and associated with the group that received the most fluid. So again, it's not true that giving a lot of fluid results in better renal outcomes. However, it's also not true that looking at any other measure, there was no difference at all in acute kidney injury. This is a separate publication looking at the renal outcomes. We had a separate NIH grant to look carefully at renal dysfunction in this trial, and we looked at it in a variety of different ways that are shown for you here. To summarize quickly, none of these are statistically significant. This is looking at AKI defined different ways, occurring at different times, looking at renal recovery, looking at renal replacement therapy use at different points. So there was no effect on renal replacement therapy at any other time point other than the one that we chose as the primary. There was no evidence of differences in new AKI or AKI progressive, either by KDIGO or by a series of biomarkers, too many to show you here, or by AKI recovery. So no difference whatsoever. Now, some have argued that, we chose saline as our fluid of choice, and you've heard a lot about potential effects of that. I actually want to focus on the second word here, which is the bolus. Maybe it's the bolus that's problematic, and I've mentioned in the past, this slide looks familiar, but the bolus, this is a trial from pediatrics, but both bolus saline and bolus albumin, admittedly in saline, had a worse outcome in children in Africa presenting to emergency room, more or less, with sepsis. Now, a lot of this was malarial sepsis, and some have argued that many of these patients may well have been malnourished with cardiac dysfunction. Sounds like a lot of my adult patients, not the malnourished part, but the cardiac dysfunction part. But there may have been differences here. But you can see the mortality signal was seen in both albumin and saline bolus compared to the no bolus group. And so maybe the bolus, maybe ramming in some fluid quickly to patients isn't necessarily always the best choice, particularly when you're doing it as part of a standard protocol and everyone is getting it, as opposed to usual care where you're deciding on the appropriate amount. But wait a minute, we have another paper in the New England. This just came out. It turns out that New York State decided that they wouldn't wait for the science to be decided, and they decided that they would legislate a requirement for a sepsis bundle, derived primarily from the Surviving Sepsis campaign, to be applied to all patients. And of course, the fluid was in that bundle. And the bundle resulted in there was evidence that when you complied with the bundle and you completed it quickly, you had a lower hospital mortality than when you failed to apply the bundle as quickly. And the longer time it took you to get the bundle delivered, the worse the outcome. And surely fluid must be driving that effect. Well, apparently not. This is the evidence for fluid. You can see it didn't matter. And it didn't actually matter whether you complied with the fluid part of the bundle at all. So what did matter? Shockingly, giving antibiotics to patients with sepsis is a good idea. And shockingly, giving it quickly, early, is a good idea. And this has been shown in a number of different studies, not just this one, too numerous to actually recount. Now, it is absolutely true, as was displayed in this another New England Journal paper, a nice review by Derek Angus and Tom Vanderpool, that these biologic consequences of sepsis that we've been talking about and studying for many years are still very much in the forefront. It's just that they're not resolved by fluid resuscitation. If you look, and this is still process data, this was the second aim of our NIH grant, recently published in Critical Care Medicine. If you look at various measures of those pathophysiologic processes I've shown you on the prior slide, inflammatory cytokines, coagulation markers, measures of oxidative stress, and measures of oxygen delivery to the tissues, if you will. These are still all highly statistically significantly associated with mortality, and they all go in the same direction. The higher the levels, the worse the outcome. And this is true not only at baseline, but it's also true at 24 hours. So the degree to which you can successfully ameliorate these effects, these biologic markers, the better the outcome. But none of these predict very well on their own, which is no real surprise, but they're all highly statistically significant. It's just that there's no effect whatsoever in terms of the various arms in the trial. Early goal-directed therapy, protocolized resuscitation versus standard care had no effect whatsoever on the resolution of these abnormalities. There's just no difference anywhere across these three arms. Now, interestingly, and this was not what we hypothesized, we did this analysis looking at either IL-6 or IL-6 and IL-10. These were defined because they had the strongest relationship with the outcome. We did a heterogeneity of treatment effect analysis using just those two markers, IL-6 alone or IL-6 with IL-10. We hypothesized that the higher the levels of these inflammatory cytokines, the more likely protocolized resuscitation would have a positive effect. And we actually found just the opposite. This was actually statistically significant. The less inflamed patients had a positive effect with protocolized care. And as you go to more severe, there was actually a trend towards harm, and this almost reached statistical significance at the top quartile. And in fact, if you subdivide this even more, you reach a harm signal at about the 6% side of that. Now, you can wonder why this is. I still think we should look at this as hypothesis generating because this wasn't what we were expecting, so you could say this is just a chance finding, although it is possible that protocolized resuscitation is actually more effective in patients that are not expected to be that sick. You know, do the protocol because it's better than usual care, because in those patients, usual care is not as good because people don't recognize that patients are sick. I think that would be an overreach, and so I don't want to leave you with that as it's a hypothesis. It could be tested. I think the actual interpretation should be that there's no effect overall, and that's how we should practice. And then lastly, in the last 30 seconds, I'll just leave you with some thoughts about sepsis as being actually, and hopefully sepsis 4, when it comes around, will finally disentangle sepsis, because sepsis, like AKI, is not one disease. It is a collection of diseases that are different from one another, and nowhere is this more apparent than in pediatrics. And so this is some pediatric data in which patients were assigned either single organ failure in about 14%. This is a relatively large overall cohort. I think it's had a couple thousand patients in it, looking multi-organ failure with some inflammatory phenotype that I'll describe in a second. Without phenotypes, is about 38%, and macrophage activation syndrome as a classic sepsis phenotype occurred in about 11%. And this is just to show you that in kids who have less comorbidity, obviously, as that driving mortality in sepsis, if you had single organ failure, no kids died. If you had immune paralysis, but you didn't have macrophage activation syndrome, no one died. If you had multi-organ failure without any of the inflammatory phenotypes, no one died. If you had multi-organ failure without either of these, no one died. If you had TAMOF, if you had an HUS TTP-like, if you had evidence of microvascular dysfunction, mortality got up to 7%. But if you were in this 11% that had macrophage activation syndrome, mortality was 65%. We decided to look at this in our adult population. This is an ongoing research, but if we look at the overall process cohort and we just begin to select patients that had hyperferritinemia, we found about 2.5%, about 36 patients out of this group, had very high levels of ferritin. I should say this really is, we looked at about 2.5%. If we then take the 6 patients that had the highest ferritin levels as a way of screening for macrophage activation syndrome, and then doing sequencing on those patients to look for genetic variants associated with macrophage activation syndrome and other inflammatory phenotypes, sort of important subgroups, it was fascinating that all 6 of these patients had genetic predisposition to either macrophage activation syndrome or HUS or Mediterranean fever as a subgroup of sepsis, and the mortality rate in this population approached 100%. So in conclusion, sepsis is a life-threatening organ dysfunction caused by a dysregulated immune response to infection. Early and appropriate antibiotic and source control, therefore, is the treatment of choice. There's no evidence that a more aggressive fluid resuscitation reduces organ injury or improves organ recovery, including AKI in septic shock. Sepsis, though, I remind you, is not just one disease, and there may be opportunities to treat important subgroups that are associated with markedly increased mortality risk. Thank you for your attention.